You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 9th, 2025. This week, the controversial KETO-CTA Study, tough decisions in subclinical AF, and a potentially huge new benefit for GLP-1 agonist drugs. First topic today is the KETO-CTA Study. The journal JACC Advances published a study looking at plaque progression in people eating a keto diet. It stirred all sorts of controversy on social media, and I will review it this week. A few background comments first. An obstacle to broad clinical implementation of carbohydrate-restricted diets and the keto diet are lipid changes that occur in a minority of patients upon carbohydrate restriction. What are these changes? Bad lipid changes, as in large increases in LDL cholesterol and associated ApoB. Now, while there are many factors contributing to the increase in LDL cholesterol and ApoB in the keto diet, leanness seems important. Get this. The authors cite a meta-analysis of 41 studies that report that mean baseline BMI had a strong inverse association with LDL cholesterol change, whereas a saturated fat amount didn't seem to be significantly associated with LDL changes. The meta-analysis found that for trials with a mean baseline BMI of less than 25, LDL cholesterol increased by like 41 milligrams per deciliter, a lot. By contrast, for trials with a BMI of 25 to 35, LDL cholesterol didn't change, and for trials with a BMI greater than 35, LDL cholesterol actually decreased by 7 milligrams per deciliter on the carbohydrate-restricted diets. I did not know that lipid changes with carbohydrate restriction was modified by BMI, but these observations have given rise to this characterization of a lean mass hyperresponder phenotype, LMHR, lean mass hyperresponder. Again, this is all new to me. Now, from the authors, the aim of the study was to examine the association between plaque progression and its predicting factors, and I know that sounds a bit confusing. This was a study of 100 people who were on a keto diet for years, actually, before entering, and they had keto-induced LDL cholesterols of greater than 190 and an HDL greater than 60 and normal triglycerides of less than 80. And the authors followed these patients for 1 year, and they used baseline coronary calcium and CCTA imaging. It was an imaging study. Now, I say keto-induced because the LDL cholesterol had to be less than 160 before adapting the keto diet. Entry criteria also included an increase in 50% of the LDL cholesterol. And plaque progression predictors were assessed with correlation like linear regression. Study subjects had to have a normal glucose and hemoglobin A1C and a normal CRP. So really these are isolated elevations of the LDL cholesterol. Here were the results. Patients on a keto diet had a normal BMI at 22 and a very high LDL of 255, HDL about 90 and triglycerides normal. So I just want to pause there and just think about what an LDL of 255 means. These were 55-year-old, mostly men, who were adherent to the keto diet as documented by beta-hydroxybutyrate measures. And over the year, there was no substantial change in ApoB or BMI. Now, the study was actually pre-registered, and the primary endpoint was originally the change in non-calcified plaque burden. Now, they did not formally present this endpoint. Instead, they gave the median change in percent atheroma volume, which they said was 0.8%, and I don't really know what that means. Who knows what that means? They tell us that this value is comparable with those observed in other cohort studies. The thing is, the primary endpoint of change in non-calcified plaque volume was presented in a figure, which you could look at, and you could see that most individuals in the study have an increase in non-calcified plaque volume. Now, this lack of data on the primary endpoint causes stir online, and the lead author eventually offered the data in a video on X. I kid you not. The numerical pooled non-calcified plaque volume change was an increase of 18.8 millimeters cubed. If this means nothing to you, don't worry. I'll come back to it. It's weird, though, that we had to get the primary endpoint in a Twitter video. The main thrust of the paper were the correlations that they made. Neither the change in ApoB throughout the study nor the ApoB at the beginning of the study were associated with a change in non-calcified plaque volume. There was also no correlation between any non-calcified plaque volume and LDL cholesterol. So what was correlated? The baseline coronary calcium was positively associated with the change in non-coronary plaque volume. So also were all other plaque characteristics measures. So to simplify this, the way I understand it is if there was plaque or CAC at baseline, there was a positive correlation with non-calcified plaque volume. Now, the authors make this case that while both LDL and ApoB are indeed independent risk factors for atherosclerosis, the absolute risk associated with an LDL cholesterol and ApoB is context-dependent and may not apply to this LMHR, lean mass hyperresponder group. Thus, they write, quote, "These data are consistent with the observation that high LDL cholesterol and ApoB among a metabolically healthy population have different cardiovascular risk implications than high LDL cholesterol among those with metabolic dysfunction." Now, gosh, that's a big conclusion because these people in this study had total cholesterols of 350 and mean LDLs of 255. But the authors make this case that the lean mass hyperresponders are different from the person with an abnormal lipids from just run-of-the-mill metabolic syndrome. Okay, difference number one, they state, that the LDL and ApoB elevations are dynamic and they result from the metabolic response of carbohydrate restriction, and this is not a genetic defect. Difference two, lean mass hyperresponders are normal weight and metabolically healthy. They don't have diabetes, hypertension, insulin resistance. Difference three, the high LDL and ApoB in this phenotype emerge as part of a lipid triad, also inclusive of high HDL cholesterol and low triglycerides, and this represents a metabolic signature of a distinct physiological state. And the difference four, they say that this degree of this phenotype is inversely related to BMI leanness, consistent with the idea that it is a metabolic response to carbohydrate restriction that is accentuated in leaner, more metabolically healthy persons. Now, the authors are not shy in making their conclusions, and I call them whoppers number 1, 2, and 3. Whopper number 1, they conclude that the lean mass hyperresponder population constitutes a unique and important natural experiment evaluating the lipid heart hypothesis in an unprecedented manner. Whopper number 2, our data are consistent with the notion that elevated ApoB, even at extreme levels, does not drive atherosclerosis in a dose-dependent manner in this population of metabolically healthy individuals. Now, they do qualify this conclusion a bit by saying that the lean mass hyperresponders phenotype may still have risk. For instance, they noted that the percent atheroma volume does increase comparable to what has been observed in other studies on populations with lower LDL cholesterols across the cardiovascular disease spectrum. They don't give a citation here, but they do qualify it. Now, their whopper number 3, quote, "These insights can facilitate personalized treatment and risk mitigation strategies based on modern cost-effective cardiac imaging. For instance," they say, despite profound elevations in LDL cholesterol and ApoB, based on their data, that the lean mass hyperresponder subjects with a CAC 0 at baseline, there were 57 of these, constitute a low-risk group for percent atheroma volume progression, even as compared to other cohorts with far lower LDL cholesterols. By contrast, the lean mass hyperresponder subjects with elevated baseline CAC, possibly from a history of metabolic damage and dysfunction prior to adapting the carbohydrate-restricted diet, appear to constitute a relatively higher risk group for percent atheroma volume progression, even when LDL cholesterol and ApoB are equal to their CAC 0 counterparts. Before closing their paper, they coined the phrase, plaque begets plaque. All right. My comments on this. I see why this paper generated a lot of angst online. The idea of the study is reasonable, I think. What's unreasonable are the conclusions. Okay, first, if you look at the primary endpoint, which was change in non-calcified plaque volume, it went up. A lot, actually, 18.8 millimeters cubes. That was 2.5 times higher than what they predicted in their study protocol. So, if you believe the delta of non-calcified plaque volume is a great surrogate, the actual data look pretty ominous. Second, imaging tests, come on, are almost always a terrible surrogate measure. Images are images. To assess risk in cardiology, you need to measure events, heart attacks, strokes, CV death. Now, I realize this is a small, uncontrolled study, and it's fine to look at these things. In fact, I'm curious. But you cannot claim clinical importance just because you weaved a nice story about LDL cholesterol in one phenotype of lean mass hyperresponders being different from high LDL cholesterol in metabolic syndrome patients. Third, there is like 50 years of data supporting LDL cholesterol being causal for atherosclerosis. Like every Bradford Hull criteria is met for LDL cholesterol and atherosclerosis. So if you're going to claim an exception, like these groups of people with total cholesterols of 355 are different, you need a lot more rigorous evidence than this. Your priors being that the lean mass hyperresponders are an exception, have to be extremely pessimistic. So if that's the case, you need really strong data to change your posterior view, and this study is surely not strong evidence. Fourth comment, assuming you believe the plaque images are precise and reproducible and clinically relevant, which is dubious, this study really suffers from a lack of control arm. All they had to do was recruit a group of people eating, say, a Mediterranean diet, then see what happens to them relative to the keto people. Now, fifth, the authors don't tell us how many people they screened to find these 100 people. I get the sense these are a highly selected bunch. Finally, the question of heart health from a specific diet is going to be really hard to sort out. Nutritional studies always are. An RCT in a prison might work, right? But cardiac events in young people, even with the keto diet-induced LDL, are going to be infrequent. 25-year-olds are pretty much bulletproof. What's more, the lean mass hyperresponders will surely do other things that affect heart disease, like they probably exercise and they don't smoke. If the authors are wrong, and actually eating a diet that causes crazy high LDL levels and maintaining a lean body mass is actually harmful, then given the popularity of these carbohydrate-restricted diets, this could be a possible public health disaster. As for diet, I do think Americans eat too many carbs, but the keto diet seems extreme, especially when it causes these kinds of LDL cholesterol elevations. I ask, why not just eat a balanced diet like they do in Sicily? All right, next topic is subclinical AF, to anticoagulate or not. JAMA Network Open has published an interesting modeling study from a Finnish group on the matter of net benefit of oral anticoagulation in subclinical device-detected AF. Now, the background here is known to anyone who practices cardiology. It is perhaps the most common question I receive. John, Mrs. Smith had 4 hours of AFib on her pacemaker. Her CHA2DS2-VASc score is 4. Should we anticoagulate? And if we don't anticoagulate, how much AFib does she have to have before we do? The short answer is, I have no idea. But your comeback is, come on, Mandrola, we have 2 RCTs in New England Journal. And it is true, there are 2 RCTs. We have the NOAA trial, edoxaban versus placebo, in 2,500 patients with a median duration of AF of 2.8 hours on their device. The primary outcome of CV death, stroke, and systemic embolism was, in fact, 19% lower in edoxaban group. The confidence intervals were wide and the difference did not reach statistical significance. Major bleeding was 31% higher in edoxaban group, and this did reach statistical significance. We also have the Artesia trial, apixaban versus aspirin in 4,000 patients with a median duration of AFib on their device of 1.5 hours. The primary outcome of stroke and systemic embolism was 37% lower with apixaban, and this did meet statistical significance. Major bleeding, however, was 80% higher, and this met statistical significance. Now, some have said that the NOAA trial was negative and an Artesia trial was positive. Perhaps, technically, this is true, but I think they both show the same thing. Oral anticoagulation reduces stroke in subclinical AF, and it increases bleeding. It leaves us with the question of net benefit. Now, I've heard Dr. Jeff Healy, the PI of Artesia, rightly say that we should favor anticoagulation because strokes are worse than bleeds, and this is certainly true. The tension in subclinical AF is that the yearly stroke rates in both trials were very low, in the 1.2% range, far lower than what would be predicted in the CHADS-VASc assessment for clinical AF. In other words, a patient has a CHADS-VASc score of 4 or 5. If they have clinical AF, their stroke rates are high, 5% or more per year. But if they have subclinical AF, these trials find that their stroke rates were low, around 1%. And if all this is true, even if anticoagulation reduces the relative risk, the absolute risk reduction from a base rate of 1.2% is tiny. It's in the order of 4 per thousand. That's an NNT of 250. Therefore, any increase in bleeding from anticoagulation may mitigate this small net benefit. So now to the paper in JAMA Network Open. This was led by senior author Dr. Consta Teppo. The group set out to estimate the net benefit of anticoagulation in subclinical AF. They used modeling techniques, and it's technical. A Medscape colleague, nephrologist F. Perry Wilson, covered this paper on Medscape, and I'll link to it. And he wrote, "The study was done using a computer. I know, all studies are done with computers, but here I mean literally." So the authors used a decision analytical model run with 10,000 patients with subclinical AF on anticoagulation and 10,000 without anticoagulation. They used a Markov decision model to estimate net outcomes of the DOACs. And of course, you all know that doctors who ablate AF and put in pacers and defibrillators, like me, don't know much about Markov modeling. I was going to ask Professor Teppo to explain this to me, and I think he would have told me. But to make life easier, I just asked my friend Claude. Claude said a Markov model consists of multiple health states individuals can move between based on specific transition probabilities. Think of it as a simulation where patients exist in various health states. For instance, they can be well, they can be post-stroke, post-bleeding event, or dead. In each cycle, now it was 1 month in this study, patients can transition between states with certain probabilities. The model tracks what happens to a cohort of simulated patients over time. And of course, the model is constructed in multiple steps. There's the base case patient, right? The researchers create a model patient, age 77, which matches the average age in the clinical trials, and then they applied the untreated stroke and bleeding rates from the NOAA and Artesia trials. The second step, the health states. The model included states for being well with subclinical AF, having ischemic stroke with varying severities, having a major bleeding event, and this included hemorrhagic stroke and other intracranial bleeding. Another state was the development of clinical AF, and of course, death. The third part of the model is transition probabilities. The pooled point risk estimates from the meta-analysis combining the two trials, this was the McIntyre meta-analysis, were used as the effect sizes for anticoagulation. So anticoagulation was 32% decrease in stroke and major bleeding 62% increase. Their model assigned an 80% weight to non-intracranial bleedings for the increase in bleedings caused by the DOACs. The fourth part of the model is event severity. The probabilities for the severity of stroke and bleeding events in the anticoagulation and non-anticoagulation groups of the model were approximated from previous observations in patients with and without anticoagulation. The fifth part of the model is the quality of life weights. The net benefit outcome was assessed in terms of quality adjusted life years, where clinical events reduced patients' quality of life based on the type and severity of the event. And this was, of course, according to previously published quality of life data. And the final part of the model was a time horizon. The simulation ran for a 10-year period with 10,000 samples in both decision groups with and without the DOACs. The main outcome measure they were interested in for net benefit was the cumulative quality-adjusted life years during the simulation. So this included things like the severity of stroke, the severity of hemorrhagic strokes, other intracranial bleeds, extracranial bleeds, as well as the number of deaths during a 10-year simulation. It's a really neat way to look at net benefit. As I said, I don't know anything more than what I read about Markov modeling, but the thing that strikes me, and perhaps it strikes you too, is that there are a lot of degrees of freedom of choices. In other words, there are a lot of inputs in this model. 80% weight for intracranial bleeding, for instance. Why not 70% or 85%? That said, here's what the model shows. Over the 10-year period, you would have 1,076 strokes in non-treated subclinical AF versus 843 with treatment. So the delta of 233 strokes saved seems like a lot, but it's only 2.3% per year. As for bleeding, there would be 1,213 major bleeds without anticoagulation versus 1,664 with anticoagulation. That's 453 more bleeds. That would be 4.5% per year. Deaths were nearly the same, 55 fewer in the anticoagulation arm, but it's only 0.6% delta per year. Okay, what about their primary endpoint of quality-adjusted life years? It was, drum roll, per patient, the difference listed led to one additional quality-adjusted week of life with the DOAC treatment during the 10-year simulation. And they state that when the 95% confidence intervals of treatment effect sizes were considered in a probabilistic sensitivity analysis, they estimated a 66% probability that DOAC treatment leads to more quality-adjusted life years than withholding treatment. So that's a 35% chance of no difference. The authors then did an exploratory analysis looking at higher risk patients, and as you would expect, in patients with CHA2DS2-VASc score greater than 4, the increase in quality-adjusted life years with the DOAC was now a month, not a week. But they note caution because this estimate came from subgroup analyses in the two trials, neither of which met statistical significance for interaction. The authors concluded that, quote, initiating DOACs in patients with device-detected subclinical AF was associated with a minimal increase in quality-adjusted life years. However, the benefits were uncertain, and the effect size of the overall net benefit does not appear to be clinically meaningful. 1 week. I really love this paper and the author's discussion. The modeling and estimates make intuitive sense, right? The trials find extremely low rates of stroke with subclinical AF. The average age of these patients was 77, and as you know, older patients have many competing risks. My friend Andrew Foy has a nice model thinking about the domains acting on treatment effect. There's overlapping circles where you have the risk of the primary outcome versus the competing risk, and overlapping circles where you have the treatment benefit versus the treatment harm. And I think treating patients with subclinical AF is a perfect example of these four domains coming together to almost cancel themselves out. The Markov model basically quantifies this to a 1 week extra of good quality of life, perhaps a few weeks longer if the patient has extremely high stroke risk. Now, the clear conclusion I make from this paper is that subclinical AF is a different entity than clinical AF. I co-authored a paper on that topic in stroke, and I'll link to it. The Finnish group has shown very little net benefit in treating subclinical AF. Now, this contrasts with the famous Singer et al. Net benefit paper in the Annals in 2010, where Danny Singer's group showed a clear net benefit of warfarin in patients in the Atria cohort. Here, even when the annual stroke rate was only 2%, warfarin provided a large net benefit, especially in older, higher-risk patients. In clinical AF, stroke reduction from anticoagulation was larger than the bleeding increase, but subclinical AF has a different meaning to us. Yes, it is electrically the same, right? The atrium is fibrillating, and when you look at the atrial electrogram, it is AFib. But, and this is my opinion, I'm beginning to think that a certain degree of short-duration AF occurs in older people as a matter of normal life. Now, we know that PACs and PVCs increase with age. Why shouldn't short-duration AFib increase? For now, the only solution to the matter of subclinical AF is to do what David Sackett described when he coined the term evidence-based medicine. That is, we align care with patient preferences. With our patients, we discuss the uncertainty here. We seek their preferences and we treat accordingly. There can never be an algorithm for subclinical AF. There can be no guideline. This problem does not fit into those colored boxes in guidelines. And the top people who write guidelines should resist the urge to help us clinicians. If a patient fears stroke and is willing to deal with the disutility of taking a daily pill, that is the cost and swallowing it every day, then fine, they can use oral anticoagulation and we prescribe it. If a patient fears bleeding more, then you hold off and you monitor more. And if they turn into having clinical AF, then you can treat accordingly. The third topic today is about GLP-1s. And it's GLP-1s and the treatment of fatty liver disease. And I know this is a cardiology podcast, but hear me out. There is a connection. Plus, the science of this study is striking. In Kentucky, where I practice, one of the least healthy states in the U.S., obesity is essentially the norm. I estimate that more than half, perhaps more of the patients I see in clinic have some degree of metabolic syndrome, that is, overweight or obese, insulin resistance, type 2 diabetes. Many of these patients also have fatty liver disease, which used to be called non-alcoholic steatohepatitis or NASH, but is now called MASH or metabolic associated steatohepatitis. It's a bad condition, and I think it flies under the radar of most of us cardiologists because we see these patients for some cardiac reason like hypertension or AFib or ischemic heart disease. Now, my friend Claude says that 9 to 15 million adults in the U.S. have metabolic-associated steatohepatitis, and it's getting worse. The prevalence in MASH in the U.S. is predicted to increase by 63% from 16 million cases in 2015 to 27 million cases in 2030. And in patients with type 2 diabetes and obesity, the prevalence of MASH is as high as 16%, so almost 1 in 5 patients. Now, New England Journal of Medicine published recently the results of the Essence trial. Essence. This had 1,100 patients with documented inflammation on liver biopsy, and it tested semaglutide versus placebo. Essence is a two-part trial. Part 1 looks at histology of the liver, and it has resolution of steatohepatitis without worsening of liver fibrosis and reduction in liver fibrosis without worsening of steatohepatitis as the primary endpoints. Now, Essence trial is ongoing, and Part 2 will measure clinical outcomes of the semaglutide versus placebo. New England Journal published a Part 1, and it is a shocking result. Now, these patients were young, age 56, more than half were females. The mean BMI was 34 to 35. The primary endpoint were twofold. Resolution of steatohepatitis without worsening of fibrosis occurred in 63 versus 34% in the semaglutide versus placebo group. That's an absolute treatment difference of 29 percentage points, which was highly significant. The second primary endpoint, a reduction in liver fibrosis without worsening of steatohepatitis, was reported in 37% versus 22% in the semaglutide versus placebo arms. That's an absolute treatment difference of 14.4 percentage points, also highly significant, and all secondary outcomes favored semaglutide. So my comments, I mentioned this study because A, oodles of our patients have metabolic-associated steatohepatitis, whether we know it or not. B, MASH is on the rise as obesity increases. C, MASH portends a poor prognosis. It is the leading cause of liver transplant. Perhaps most relevant to cardiologists is that most patients with MASH die of cardiovascular complications. Now, the GLP-1 agonist drug, in essence, basically shredded evidence of liver disease, at least histologically, and I suspect the follow-on outcomes portion of Essence will be stopped early for benefit. Now, there is an approved medication for MASH, and it's called resmetirom, but this is a thyroid hormone receptor selective agonist that specifically targets the liver, and other than its mild lipid-lowering effects, it has no known CV benefits, which is unlike GLP-1 agonists, which have RCT-proven benefits in cardiovascular disease and diabetes. Now, I'm not yet prescribing GLP-1 agonist drugs, but like the SGLT2 inhibitors, I think GLP-1s will soon be a drug that cardiologists will want to prescribe. Now, I realize that some listeners may say we should be treating obesity and obesity-related diseases with weight loss and diet and exercise. The GLP-1 benefit seen in the Essence trial was likely due to weight loss, and indeed, the semaglutide group lost a lot of weight compared to the placebo. My answer to that notion, though, is it doesn't matter why the GLP-1 drugs work. When trials show that something works, an evidence-based practitioner should embrace it. Now, what's more, clinical medicine is pragmatic. It's pretty obvious that lifestyle interventions have a low success rate. So, if the GLPs work, we should prescribe them. And finally, my friends, there is a big difference in using a GLP-1 agonist in an adult who has diabetes, heart disease, and liver inflammation for treatment of disease versus an adolescent who is overweight. Now, the former person, our patient, is in real trouble. The net benefit calculus favors treatment. The younger person should be counseled aggressively to change lifestyle. In other words, treatment of disease is different from prevention. Okay, finally, before I close, I wanted to mention that I have a column up on the heart.org Medscape Cardiology. A few weeks ago on this podcast, I discussed the FAME-3 5-year results. I turned this into a column. The short story, as you remember, is that FAME-3 was designed as a 1-year non-inferiority trial comparing FFR-guided PCI to CABG in patients with multivessel coronary disease. Now, why someone would want to compare revascularization strategies at 1 year is mysterious, but that is what they did. And CABG was much better. FFR PCI did not even reach non-inferiority in a 4-point composite of death, MI, stroke, and unplanned revascularization. My column pushes back against the claims in the 3- and 5-year results that magically FFR PCI is now equivalent to CABG. That claim stems from use of a different endpoint. So take a look at my column and see what you think. And that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating on whatever app you use. This helps others find us. And of course, if you disagree with something I said, send me a note, write a comment. I learn from these comments. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.